Hi guys, my name is Erin Schroeder. I'm a physician assistant and I graduated from the IUPA program almost 2 years ago. Since then, I've worked in orthopedic surgery. I did that for a little over a year and a half, year and 3/4-ish, and then recently made a transition into cardiovascular surgery. Both of those were awesome experiences for me. Get to be in the operating room, but also get to manage patients, which has been really enjoyable. Um, Disclaimer before we start into the presentation. I am sitting in a cabin in the woods or outside a cabin in the woods, so if you hear the sounds of nature, I apologize. It was either that or screaming children inside. And that still might happen, as is the nature of virtual teaching. So let's go ahead and get started. When I start the video, start the presentation, it takes away the video, but if you guys have any questions, you can always email me afterwards. So that is if it will let me present here. All right, so patients with special preoperative needs. The reason you really need to, we need to go over this is because being in a subsurgical specialty, sometimes it's easy to get isolated into thinking only about what you need, right? There's a constant joke in orthopedics that the heart is there to pump blood to the muscles and bones. But at the end of the day, we all acknowledge that it's important. So understanding that you need to look at the whole patient and realize who needs additional evaluation. Disclosures for both of these, I don't have any disclosures, which is great. So objectives, really the biggest thing is being able to recognize who needs special attention. Additionally, if you are in primary care or a subspecialty like pulmonary care, endo, cardiology, what additional testing patients need, and then how to manage those patients. So when I say special preoperative needs, there's an exhaustive list, but this is the main thing, right? These are the people that when I'm evaluating their past medical history, these are the ones that really stick out to me as needing to ensure that their disease pathology is stable and that it's not going to have any effect on their surgical outcomes. So Case 1, so this is one of my patients. She's a 58-year-old female. She's got uncontrolled diabetes, history of TIA, multiple stents, and chronic kidney disease, and she was coming in for a follow-up of her diabetic frozen shoulder. So we'd done all the conservative treatment options. She wanted to move forward with surgery, and I was looking at her recent labs, and her most recent A1C is 9.2, creatinine is 1.6. She has a very long medication list, but included in that is aspirin and Plavix, metoprolol, atorvastatin, Lantus, lisinopril, and Humalog sliding scale with her meals. So first talking about the diabetics, right? And one thing you will learn as you begin to practice is that there is no specialty where you will not only encounter diabetics, but where you will not have to talk with them about sugar control because it affects everything for them. So in the surgical realm, diabetics, they don't heal well. We know that because they have microvascular damage, right? And so they have increased risks of surgical site infections. They typically have longer hospital stays, and unfortunately, they do carry a higher postoperative death and complication rate than other patients. And I know this seems intuitive, but preoperative glucose control leads to improved postoperative outcomes. And what that means is that basically, in general, most of our patients, if they have good preoperative glucose control, it's because they're good, compliant patients. And then if they're doing it well beforehand, they're more likely to do it afterwards. But sometimes this actually can be good motivation for patients. So when I was doing orthopedic surgery, my surgeon had a mostly hard and fast rule of not operating, especially for joints, on patients who have an A1C over 7.5. So if patients been in chronic pain, they're having problems, and you give them that set goal, their A1C is 10. We had a guy that took it down in 3 months. He talked to his doctor, got him more medications, improved his diet, and 3 months later he came back and saw us, and we were able to do a shoulder replacement, which was very cool. But I will say, the literature, there's really no set desired A1C. I think each specialty and surgeon is different based on what they've seen from their outcomes. But just kind of defer to your surgeon and kind of see what they prefer. In general, you want it to be controlled, which most people consider to be a 7.5 or less. But each person's different. A big thing about if you are a surgical PA, a lot of times you might be giving medication instructions pre-operatively. So I'm going to try and hit that for almost all of these medical conditions. So the big one for diabetics, as you guys probably remember, is that metformin, especially if they're getting IV contrast, should not be taken that morning. I actually tell them to not take it that morning, and if they're getting IV contrast, they shouldn't take it the morning before either. People always ask this, right? Because we always tell them that they should be NPO after midnight, meaning nothing to eat or drink after midnight. I clarify that for them. I say no breakfast, no coffee, no water, because some people don't count coffee or water as being NPO. So I always tell them that. And then almost every person asks, what about my medications? So for the diabetics, no metformin definitely that morning. And if they're getting something like a spinal epidural, then they shouldn't be in with contrast. For like our pain management people, then they definitely shouldn't be taking it the morning before either. The big one for our diabetics is talking to them about their insulin. You'd be amazed how many of them don't take it correctly anyways. But I always remind them that they should take their basal insulin at night. So like their Lantus, their nighttime insulin is okay, but they should not be taking any of their prandial insulin because they should be NPO, right? So they shouldn't need any mealtime short-acting insulin because they're not taking in any food. So that's a big one just to make sure that they understand that. Once diabetics get to the hospital, they're in the preoperative area. Every single one of them gets a random glucose check, mainly because their blood sugar can have effects on anesthesia and also on complications during and postoperatively. So the goal is less than 180. That's what we prefer. If they're anywhere between like the 180 to 300 range, depending on the urgency of the surgery, they might just give them a bolus of insulin to kind of bring them down to less than 180. But greater than 300 is most likely going to require postponing surgery if it's truly elective. The reason being is that taking someone from 300 to 170 that quickly is never good because that person probably lives at 300, especially if they're coming in fasting. So you don't want to cause any problems then and there. I have had patients get rescheduled because they come in fasting sugars greater than 300. So it's something you want to talk to them about ahead of time. Usually I ask the patients, what is your fasting blood sugar every morning? Because that's going to give me a really good idea of what it's going to be the morning of surgery. Additionally, the ideal for everyone would be tight IV insulin control in the perioperative period. Obviously, not every patient that's getting surgery is going to be admitted so that they can have IV insulin. But like for our big cardiac surgeries, they go on an IV insulin glucose stabilizer, is what we call it. Basically, they get their blood sugar checked frequently, and then they get IV insulin for correction to a goal. And we do that because postoperative hyperglycemia over 140 has an increased risk of surgical site infections. And I actually find that to be a funny statistic because 140, average blood sugar of 140 is an A1C of 6.5. So being diabetic has an increased risk of surgical site infections. But again, most of our diabetic patients, that would be great if all of our diabetics had that good of control. But I always have that discussion with them. Say, hey, afterwards, you're on Humalog, you're on Lantus, you might have increased sugars postoperatively, but really work hard to keep those controlled. And a lot of times the patients are understanding of that. Whether they do it or not is unfortunately not up to you, but just having that conversation with them. So moving on to cardiovascular disease, I as I'm sure you guys can all imagine, this is a big one when it comes to surgery because we are using a lot of medications to put these people to sleep. Our anesthesiologists need to have a good idea of the stability of the cardiovascular disease. It changes what medications they can use. It changes it changes the risk assessment of the surgery. So if you are evaluating a patient and they have a significant cardiac history, then you need to send a cardiac clearance form. Most likely they are established with a cardiologist, but sometimes family practice manage these people pretty well. So as long as they're being sent to whoever is managing their cardiac disease, but you need something from them. Additionally, so if you're a primary or you are a cardiology PA, this would apply to you. I do not order preoperative stress testing because, when I was in orthopedics, I did not order preoperative stress testing because that wasn't my specialty, right? I didn't know, did they want me to get a stress echo, dobutamine stress, whatever it might be. But that was outside of my scope of practice being an orthopedic PA. But this is really important for our primary and cardiology PAs. And there are all kinds of ways to kind of figure that out. And I even have a chart in here for one of them. So, but these things, obviously, if they've got unstable angina, you're probably not evaluating them for surgery, for an elective surgery anyway. But, recognizing, have they had a recent MI? And we'll kind of go over what the recommendations are for that. Do they have AFib, paroxysmal, consistent? Is it rate controlled, but they're on warfarin? Do they have significant aortic stenosis where they're being evaluated for a valve replacement? Do they have a pacer? Why do they have a pacer? These are all really important things just to have evaluated beforehand. So these are things that should trigger in your brain, yeah, I need to have this patient evaluated. Obviously, if the patient has symptomatic cardiovascular disease, your surgery is probably going to be postponed because they're going to come to people like me now and my counterparts and my surgeons to have that addressed before they have something like a knee replacement. So this is a really good chart from UpToDate. And so this is basically a way as a primary or as a cardiology PA to kind of evaluate, do I need to get additional testing on this patient? So obviously, if you're getting a cardiac clearance form, it's probably not an emergent surgery because the patient's already in the OR if it's an emergent surgery. Obviously, they're probably not having ACS because they'd be moving to the cath lab, all different kinds of things, but kind of moving down to this middle area, right? You're going to be looking at their perioperative risk, and there are a lot of different risk calculations that I can kind of show you that, but then you can see, like, are they low risk? No, they probably don't need further testing. Are they elevated risk? And then what's their functional capacity? And you can kind of isolate that out with all different calculations. You can go to MD Calc and find a lot of different ones. And then it kind of gives you a good idea of what do I need to do, right? Do you not know their functional capacity? Well, if that's a problem and they have poor functional capacity, then they might need a stress test of some kind, right? So these are things that as a family practice PA, you're going to get really good at isolating out because you're going to get these forms frequently, right? These are your patients that you manage, and patients need surgery sometimes. So this is a really good one. You can find this on UpToDate. This is one of those risk assessment things. Basically, this one's kind of isolated down more to a cardiac type risk, it says, probability of life-threatening complications. But this is really important, right? So when I was in orthopedics, this was an important thing to really evaluate in my brain for like our hip fractures, for example. Those are things that we almost always operate on. But if I went down and I see a hip fracture and they've got JVD on exam, I'm concerned, right? Because that means they are either chronically overloaded or they're currently having a heart failure exacerbation, and that's definitely going to increase their risk during surgery. So these are things that you can kind of isolate down. If they've had an MI within 6 months, it definitely is going to bump up their risk during and post-operatively. So that's an important one. I don't know if I'm going to be able to get this to pull up and record for you guys. This is No, I don't think it's going to record for you. But so this is a calculator that helps for in my current practice, so cardiac surgery. And what it does is you can go through and you can put in, they have aortic stenosis, they've never had an MI, they have hypertension, this is their current creatinine, and it's going to give you a spelled out list of, what's their risk for mortality, what's their risk for morbidity, what's their risk for AKI, and so it's really good. It's a really good calculation. And so I'm sure that whatever specialty you're in, they're going to have those kinds of calculators so that you can actually give an appropriate, assessment to your patients of these are the risks that we're looking at going into surgery. So, additionally, cardiovascular disease, they are almost always on the slew of medications. I know that Stacy taught you the post-op, not post-op, but post-MI medications. Those are almost always the same as post-PCI medications, post any cardiac intervention medications. They're pretty standard. So if you see someone with cardiovascular disease, you need to know, well, what do I do with these cardiac medications? And the biggest one that's most important is their beta blocker. So there have been a lot of studies that have shown that beta blockers are actually cardioprotective, both intra and post-operatively. So it's very important that if a patient is chronically on a beta blocker, even if they haven't had cardiovascular disease, if they just take, metoprolol for hypertension, even though that's not the standard anymore, but if that's what they're on, they take it the morning of surgery because it does provide cardioprotection for them. So I'm always very careful to review the medication list with patients, and if they're on a beta blocker, I write it in big bold letters on their preoperative packet, take metoprolol the morning of surgery. And I tell them just to take it with a small sip of water, but that's always the big one that I hit home for them. Additionally, if they're taking an ACE or an ARB, if they're on that lisinopril, they should not be taking that morning, because the last thing you want to do is exacerbate any kind of hypoperfusion. So we always hold that the day of. If they're taking something like digoxin, they should definitely take that the morning of surgery. That kind of goes for any medications that are measured by blood level. So definitely digoxin is a big one. That's going to also help. Obviously they're probably on it for either heart failure or AFib. So if they are taking that, you want them to continue with that morning. From an anticoagulation standpoint, one of the biggest reasons you are asking for cardiology clearance or primary clearance, if they manage it, is when can they stop their anticoagulation, right? Are they healthy enough to stop it? Are they healthy enough to undergo surgery? And additionally, when can they stop it? So these time frames that I have listed on this slide, these are the general of, if they say yes, okay, you can stop these medications, this is typically when they say you can stop them at. Plavix, people who take Plavix, they ooze a bunch during surgery. If you can make it to that 7 days, that's great, because by then most of the platelets that are inhibited are washed out and you have new platelets so that they can actually clot. NOACs definitely are typically on the shorter side, which is a bummer because they bleed a lot on those as well. And then warfarin, it's usually about 3 to 5 days, depends on the patient, depends on their risk factors. And then some of these patients may require a Lovenox bridge, which is fine. I typically allow the primaries or the cardiologists to manage and prescribe that, but sometimes we can do it for them. So staying on the same kind of things, having cardiovascular disease that's stable going into surgery is great, but it's also different from having recent unstable cardiovascular disease. As you guys know, when people have MIs, it can cause ischemic areas within the heart, and hopefully with the revascularization, that tissue can recover. But by doing surgery, you're putting a lot of stress on the heart. And if you've got ischemic areas that are still trying to recover, then you need to you could be setting yourself up for a big problem. So in general, the guidelines recommend holding off on elective surgeries for 3 to 6 months after an MI. I will definitely tell you, I have never seen 3 months. I assume that that's going to be probably more for urgent cases, surgical intervention for cancer, those types of things. And the patient really needs to be shown that they're stable. From my experience, I have seen no earlier than 6 months after an MI. Obviously, that's in the orthopedic elective surgery. In the cardiovascular surgery world, you're operating either then and there or about a week later once they have a Plavix washout from their cath. So usually these patients are on aspirin and Plavix or Brilinta, whatever, or Effient. I don't see Effient very much, but Brilinta is out there. And so you need to know from cardiology, when can they have surgery, but also when can they stop anticoagulation. So a lot of that depends on what kind of PCI they had, right? Did they just have a balloon angioplasty where they just kind of expanded that coronary? That's 4 weeks, which is awesome. Bare metal stent, they usually need to be on their Plavix for 4 to 6 weeks before they can stop it. But the biggest one and the most commonly used one is a drug-eluting stent, right? And with that, they actually have to be on, the cardiologists prefer that they be on their Plavix for 12 months before stopping it. That is a big deal. I have had patients who have literally had to wait 12 months status post MI to have joint replacements. Because at the end of the day, you are risking clotting off a stent that was placed for an MI if you come off your Plavix too soon. So when I see that, if I see that a patient is status post MI and I'm talking to them about surgery, I almost always ask them when they had it. Drug-eluting stents are probably the most popular ones used, so I can kind of set them up. I might have their cath report in their chart so I can look at it. But additionally, I just kind of set them up at this point. Okay, well, that was 8 months ago. I'll tell you that very commonly we're not able to do surgery after a heart attack until 12 months. But I'm going to look into this. We can work on getting the clearances and all those types of things. But I kind of set them up so that they know we're not expecting to do surgery next week. Additionally, once cardiology makes their recommendations of when they can stop, they almost always tell you to continue aspirin in these patients. Generally, it's a baby aspirin, so it's not the end of the world. You can do surgeries on a baby aspirin. But I just wanted to let you guys know that typically they say yes to Plavix or Brilinta once the time frame is up, but no to aspirin. So moving on to our renally impaired, as I'm sure you guys know, your renal patients just have a lot of complications. They don't heal well. We know that the kidneys and the heart are closely linked. So it makes sense that they would have increased risks. So if a patient does have chronic kidney disease, they do have risks of postoperative morbidity and mortality. And obviously our patients with the most severe renal disease, those on dialysis, do have the highest risk. And part of it is they just have bad perfusion and everything as well. I love this. Preoperative CKD is the strongest predictor of postoperative kidney dysfunction. Obviously, if your patient already has a creatinine of 1.2 and then you do a big surgery and they have hypoperfused kidneys, they're probably going to get an AKI. So those are just things to keep in your brain as you are managing these patients and kind of talking to them about. I will say that for patients with preoperative CKD, if they're older or if they're doing a high-risk surgery, especially if you need contrast, I usually get a BMP, make sure that their creatinine's doing okay and that their electrolytes are okay, and that does help guide anesthesia as well. A lot of anesthesiologists like to do Toradol for postoperative pain control, which is a great medication, but being an NSAID, they're not going to use that in a patient that's got a creatinine of 1.6. So those are just good things to kind of preoperatively think through. So trauma surgery. I love this slide because trauma is such a broad, it's such a broad category, right? So when I was in ortho, trauma looked like a hip fracture or a distal radius fracture. I didn't get to see the big eviscerations like you see at the bottom, not eviscerations, but big skin wound problems along with those things. But I have seen, knife wounds and things like that. So trauma is a pretty broad spectrum, right? And what you're going to do when you're evaluating these patients is you need to decide how hemodynamically stable are they. Obviously, if you've got free fluid in the abdomen, you're in a little bit more of a rush than a distal radius fracture. So the unfortunate thing with trauma is that if it's truly an emergent surgery, you really don't have a whole lot of time for preoperative risk reduction, right? You don't have time to optimize this patient's respiratory function or optimize their cardiac function. And so you have to really go with what you know, right? You need to make sure you do your primary survey. These patients almost always have high volume loss. Not almost always, sorry, if I'm talking emergent, there's a reason that it's emergent. And so you need to make sure that you have, your 2 liters normal saline or LR. You need to make sure you have packed red blood cells, FFP on hand. Get your lab studies, right? Because again, this is going to be important for your anesthesiologists. Knowing their CMP, do they have liver dysfunction? Does that mean they're going to bleed even more? Do they have low platelets? Do you need to make sure you have platelets on hand? All different kinds of things, ABGs. These are all the standard stuff you do in a trauma evaluation anyways, but thinking through them from a surgical side of things. I know as far as imaging goes, I think you guys are learning ultrasound now, which is awesome. We did not have that when I was there, which has been a huge addition to our program. Making sure you get your FAST exam done. Obviously, that's one of the biggest ways that we find free fluid in the abdomen now, which takes you right to the operating room. So I think that that's a great thing to have in your pocket. Also getting x-rays, making sure, you have your C-spine, chest, pelvis, all of those things. And then additionally, thinking through your preoperative antibiotics. Every patient that goes into the operating room before incision gets preoperative antibiotics. But if you have something like that leg that we just saw, that is an open, nasty wound. It probably was done somewhere in, with like a lawnmower or outdoors. That seems like an outdoor type injury, right? So you need to be thinking, what kind of coverage do I need? And those patients, they're going to have antibiotics for a while. But it is something to make sure you think through, right? Is my standard Kefsol going to be enough coverage for this patient? So back to my patient from earlier. So we decided to sign her up for surgery because she had just been through multiple conservative managements and was not getting any better. So as I was reviewing her medications with her, as I listed earlier, which of the following medications should she take the morning of surgery? So she's on lisinopril, metoprolol, Humalog, and Plavix. And if I didn't drive it home enough, they should be taking their metoprolol the morning of surgery. You should be taking your beta blocker that morning. Some people, at least in the cardiac field, will tell them they can take it the night before if they don't want to, take it with a small sip of water that morning. That's fine. But they need to take it probably within 12 hours of surgery. And so I always drive that home for my patients. Lisinopril is an ACE and ARB, right? We don't want them taking that. Humalog, that's her short-acting insulin. She should be NPO. And then Plavix, we don't want them taking that the morning of surgery unless otherwise instructed, which is rare. As you describe the risks of surgery to this patient, you discuss with her the importance of perioperative tight sugar control given her uncontrolled diabetes and A1C of like 9.2. Which of the following is an optimal random glucose at the time of surgery? All right, so 210, that's obviously not ideal, not terrible. But 40, obviously that person is way hypoglycemic and you need to adjust that. There are other problems that are most likely happening. 140 is the answer. That's where we would really like people to be. Less than 180 is the goal. Unfortunately for this patient, she decided, she was told to stop her Plavix 5 days beforehand, stopped it 2 days beforehand, and at the same time decided to stop all of her insulin. So she had not been taking her basal insulin or her short-acting insulin for 2 days. So she came in with a fasting blood sugar of 450. So her surgery got rescheduled. There was no way we could bring her down to 180 without causing significant problems. Okay, so postoperative care and complications. This one's a little bit longer. We're going to move into this just for a little bit, and then we will take a break after that. So there's a lot of complications from a surgery side of things, but we're going to go over common ones, okay? We want you to be able to recognize these. We want you to be able to then manage them, but really talk about prevention, because you might, when you go out on your surgery lectures, you might you see things that you don't understand why we're doing them. And if you can say to your surgeon, oh man, we're doing that to prevent this, right? It might, I think that would be a good thing, right? Looking for ways to prevent problems before they happen. So we'll move into this a little bit. So we've already talked about preoperative MIs, but now we're going to talk about, perioperative MIs. So unfortunately, a perioperative MI is one of the leading causes of postoperative death. For the if they have an MI, it can cause up to 40% of postoperative myocardial injury. Right? There can always be some hypoperfusion depending on the patient's severity of their coronary artery disease. But if they have an MI, that's going to bump that way through the roof, obviously, because it's causing ischemia, most likely to that area. And unfortunately, in our cardiac patients or our high-risk patients, the mortality can be over 65%. And one of the things, from a post-operative complication side of things, I always tell people the biggest one you're going to hear about is in the immediate perioperative period. So when you roll that patient back over to recovery, you're going to first hear about people complaining of nausea and vomiting. It happens. A lot of times it's just the anesthetics, they cause that. And then there's also respiratory problems, not being able to come off the ventilator, those kinds of things. But cardiovascular events are actually the third most common thing in the perioperative area. Doesn't mean it's always an MI, but in that immediate postoperative period, they're the third most common. So that's why it's a big deal to make sure that you are watching these patients, especially if they have pre-existing disease. An MI, it's most common in the first 24 hours to 30 days. I have seen statistics that say it's most common in that first 24 hours, but they're not out of the woods, right? I would say at least the literature says that at least half of these are asymptomatic, and a lot of that is because these patients are on a bunch of pain medication. Some of the times they're still asleep, right? So these are important things to be watching. What we do from a monitoring side of things is every patient, obviously during surgery, they are on telemetry, and then what we do when we move them over to the recovery area is they continue on telemetry until they are stable. For those that need it, they do continue on the floor if they're admitted. But you're watching for EKG changes, right? If you have a high suspicion, you should be getting a 12-lead EKG to ensure. And then you can get troponin, CKMB. I know that Stacy taught you guys how to diagnose an MI. There are some people who in high-risk patients will get a preoperative troponin, so that if there's concern afterwards, they can get a postoperative troponin. I haven't seen good literature for this. I will definitely say I've seen in the cardiac world, cardiac surgery world, it doesn't really make a whole lot of sense to trend troponins postoperatively. I know some people do it, but if you think about it, we're damaging the heart by stopping the heart and not providing significant perfusion during that time. We do the best we can, obviously, to not cause problems, but I just wanted you guys to be aware that there are surgeons out there who might do this. If you do have a patient who is in the immediate postoperative period and you have a confirmed MI, obviously this needs to be a group decision, right? So let's say you have you just did an open abdominal surgery, right? And you are post-op day 1, and this patient has an MI. And if you guys remember, when you're going to the cath lab for PCI, you've got to Plavix load these patients, right? So you could be talking about, you have to talk through the risks. So Plavix loading an immediate postoperative patient is going to make them bleed into their surgical site, right? So those need to be group-based risks. I'm not saying that one is better than the other, but that's where you really need to have, from a surgical side of things, really discussing these things with the family, discussing them with cardiology, having hospitalists on board, because this needs to definitely be a group-based decision. Arrhythmias, these are very common, especially in the immediate postoperative period. We see these a lot in recovery. Most of them, though, are either like Brady or tachyarrhythmias, like benign patients going down into the 40s or up into the 110s. You see a lot of PVCs and PACs as well. Obviously, the big ones that we're concerned about, that we're watching for, are unstable arrhythmias, right? New onset AFib, torsades, VT, VF, complete heart block. These things, if you've got a patient that goes into VFib, obviously you're going to be calling a code. But these are big things you want to watch for. They're treated the same way that you would treat them for an ACLS or arrhythmia protocol. Really, what we're looking for postoperatively from a rhythm perspective is you would obviously like normal sinus. And the lower the heart rate in that 60 to 80 range, the better, because what it's doing is it's a slow enough beat that there's a low oxygen demand, but because, as you guys know, the coronaries fill during diastole, so there's enough time for the coronaries to actually optimally provide oxygen delivery. So that's the goal. Doesn't mean that always where it has to be, but that is the goal. The biggest thing is if you have a patient who had pre-existing coronary artery disease, and then they go into heart block after your knee replacement, you need to be thinking MI now, right? So because there's nothing you did during your knee replacement, right? And they shouldn't be moving into heart block without some kind of reason. Obviously that's a standard if they're not post-op, but you really need to make sure if you have a new onset arrhythmia in pre-existing CAD, you need to be working them up for an MI. So moving to pulmonary complications, I might actually take a break now because this one's a little bit longer, and then we can finish out the lecture. So Sean, at this point, you can just pause it for the patient or for the students, and then I'll go ahead and keep moving just so that we have everything together. All right, so pulmonary complications. These are obviously extremely common postoperatively. Generally, it's because you're putting a tube down a patient's throat. You're inhibiting their respiratory drive, and so that's why people get these. Obviously, our people that are most at risk are smokers, people who already have pre-existing lung conditions, longer surgeries in general. Have higher risk for complications, head and neck, upper GI, thoracic. Obviously, if you're messing with the lungs during surgery, you're probably going to have a higher risk for pulmonary complications. And then if they're on the vent for a long time, because as we know, being on the vent is not ideal for an extended period of time. So the big thing when it comes to surgery is we actually have a lot of stuff to help prevent pulmonary complications, right? The biggest, first foremost, if you can get your patient to stop smoking, kudos. There are some surgeons who will say, I will not operate on this person until they stop smoking. That is surgeon dependent. I will say where I worked for orthopedics, it was in a rural community in Indiana where probably 80% of the people smoked. Then we would have never operated. But it was something we always discussed with them. Hey, as a 1 pack per day smoker, you have increased risk of lung problems postoperatively and the other problems that brought as well. But it was something we always discussed with them. Another thing is just pre-optimizing their respiratory disease, right? If you've got a COPDer who is supposed to be on a long-acting inhaler plus a short-acting, ask them about that. Can't tell you the number of times I discussed with a patient, I was going through their medication list, and I'd say, oh, okay, I see that you're on albuterol, and they would say yes. And I'd say, how often do you take that? Every day. Okay. And then I'd say, well, what about your Advair? And they say, oh, I just take that as needed. And I don't think maybe it's a education thing from the beginning of when they start their inhalers, but I think most of them just choose, they don't feel better when they take their Advair like they do when they take their albuterol. So this is actually a great time for those of you who are going to be subsurgical PAs, because I almost always talk to them about this. And what I tell them is that Advair, that long-acting inhaler, is actually really important in this, perioperative period. And so I tell them, I say, okay, surgery's in 2 weeks. Every day for the next 2 weeks, you're going to take this twice a day or whatever their instructions are for that inhaler. And I tell them, I said, if you take this every day, it's going to, help you during and after surgery, and you should continue taking it twice a day. Because that's going to decrease your risk of pneumonia. And almost all of them, if they have COPD, they're concerned about getting pneumonia at some point because they already have problems breathing. And you'd be amazed because they actually do it. So not all of them, but a lot of them really do it. And I do have them take their long-acting inhalers the morning of surgery. This is helpful for our anesthesiologists. So just making sure you have those discussions with the patients. Another thing that has been huge and has really made strides, at least in the cardiac and thoracic surgery world, is what we call prehab. So rehab is afterwards, right? So we call this prehab. And what this is these patients go to basically cardiac therapy beforehand, and they work on their cardiovascular function or their lung function to optimize it before surgery. And they've actually, there have been a lot of studies about this, and specifically for cardiac surgery, they've shown that patients that do prehab, they have reduced postoperative atelectasis and reduced postoperative pneumonia, and they have shorter hospital stays. Unfortunately, that doesn't show any kind of change in the need for prolonged ventilation or any changes in the mortality. But those are big things, right? They probably have shorter hospital stays because a lot of times we're keeping people for atelectasis or concern for pneumonia. So if we can really optimize their cardiac or lung functions beforehand, then that's a great thing. Another thing specifically for pulmonary is talking about types of anesthesia that can be used. And I love this because I think a lot of times we think of anesthesia as just being the people that put you to sleep and keep you to sleep, right? They intubate you, they keep you asleep, and that's it. Anesthesiologists are unbelievably smart, and they have a slew of things they can do to help you. One of the things in the orthopedic world they can do is a regional block or a spinal. The regional blocks are pretty cool, so I did a lot of shoulders. So what they do is an inner scalene block, and what it does is it numbs all the sensation of that upper extremity. So if they do it on the left side, it's the whole entire left upper arm is numb. They still have motor function, but they don't feel like they do because they can't feel it, right? It feels like their arm is asleep. And so what that does is it actually decreases they don't have a pain stimuli, so it decreases the amount of sevoflurane or whatever their anesthetic is to keep the patient asleep, but decreases the amount of gas they have to use because there's no pain stimulus. So that's really great for our pulmonary patients because less gas, they don't have to inhibit them nearly as much. So these are big things that help. Obviously you can talk to your anesthesiologist, but they're doing the best they can to do lung protective ventilation. But one of the biggest things when it comes to pulmonary complications is early mobilization. And one of the best examples of this is that years ago when they were not in the far so distant past, when they were doing knee replacements and hip replacements, people were staying in bed for a long time. They were staying in bed for like 3 days until they got up to move, right? Because they were in pain. That's reasonable. But they found that these patients were getting pneumonia or they were getting pulmonary complications. And so what they did is they started getting them up. And when I was doing knee replacements, we had patients getting up out of bed by the end of the day. And so what that did is, as you guys are probably aware, getting up and walking, you have to breathe harder, and so you than you do sitting in a bed. And so it helps to decrease your postoperative atelectasis. We do this with our cardiac patients as well. As soon as we can get them out of bed, we do. And we try to do it multiple times a day because that does really help their lung function. There's even been a really big push over the last few years in ICUs where they are getting patients who are ventilated or who are on ECMO. They are waking them up and they are walking them around the ICU, which is just a crazy sight to see. Obviously, they have to be stable and those types of things enough to wake them up, but it's helping them, right? If they're on ECMO, like VV ECMO, then maybe they are having a lung problem, and so it can help them rehabilitate their lungs while something else is taking care of the oxygenation of their blood. Another thing, pain control. Sorry, I know this is a long list, but this is important, right, to think through for your pulmonary patients. Pain control is big. Say someone just had a left thoracotomy and it hurts because they spread their ribs, right? So if you can give them adequate pain control because it hurts to breathe, then that will help. Last thing that I will push home until the day I die is incentive spirometers. That is this little machine off to the left here. So what this is it's actually run by breathing, right? It doesn't do anything other than that. And you'll see this on your hospitalist rotations as well. They give it to almost everyone who's in the hospital. But what it is they put their mouth on that tube and they breathe in really slowly. And what it does is it provides negative pressure. So it increases, they can kind of see how much volume they're getting in their lungs. And each day you increase that goal, right? So that they can take bigger, deeper breaths each day. And this is an awesome tool. It's good for patients that can't get out of bed, especially. And I tell patients, do it on every commercial break when you're watching TV as much as possible. Obviously, you don't want them to hurt themselves or kill themselves by doing it too much. But it's a very, very useful tool. Additionally, anytime we talk about pulmonary complications, you have to talk about VTEs. So most patients, if they are inpatient, unless they have a contraindication, they're going to be on prophylaxis of some kind. Okay, so aspiration. This is a big one in the surgical world because when we are putting them to sleep and intubating them, we are inhibiting their gag reflex, right? So we are providing enough CNS depression that they do not have a gag reflex. And so there are times that patients can aspirate. In general, this comes with thoracic or abdominal surgeries, but the biggest thing is if they have a truly gross aspiration, meaning that they have a lot to come up and go into their lungs, if that progresses to pneumonia, there's a 50% mortality for that. So that's why we are so careful in the surgical world. Everyone thinks about this. They do so many things to prevent it. Risk factors, obviously, if someone is a trauma emergent surgery, they could have eaten an hour ago, right? So they could be aspirating Burger King. So you have to understand that those are big risks with those surgeries. If they already have a history of reflux, that obviously can contribute to aspiration. And then pregnancy is a big one too, because if you guys don't know this, most pregnant women get reflux. The biggest things is when we get to the recovery area, you're going to see a million things happening. Anesthesia is going to be talking to the nurses. There's going to be another nurse working on X, Y, and Z things. There's going to be your room nurse transitioning to another nurse. So there's a lot of stuff going on. But one of the things you will see every single time is you will have a nurse listening to the lungs. They will stand there, they will listen, and then they're going to say something like 16 clear. Right? So what they're doing is they're calling out your respiratory rate and then what the lungs sound like bilaterally. And the reason they do this is because if you have had a gross aspiration, there is a higher chance that you are going to have tachypnea and rales. So if you are sitting there and you're doing your thing, because this isn't really your time, right? You're just there to make sure the patient's stable, not going to have an acute event. If you hear 24 and rales, in the right lower lung, that's a problem, right? Obviously, it's not something you're going to address, but anesthesia is going to address it, right? So there needs to be those things where we are thinking about it, but they do so many measures, and that's why they do this, because they need to know if they've had an aspiration event. Treatment for aspiration, they can do suction. Sometimes you might even need to do a bronchiolar lavage, but most of these patients are put on empiric antibiotic treatment because we don't want it progressing to pneumonia. From a prevention standpoint, preoperative fasting is very important for this reason, right? And I even tell people, no water, no water, no water, because you can still aspirate water and it can carry gastric juices up into your lungs, which is not something that anyone wants. Proper positioning is another thing, making sure that you aren't putting increasing abdominal pressure or anything like that could cause a problem. And then appropriate intubation. A lot of anesthesiologists these days are using LMAs, which kind of provide a little suction cup over the airway. So hopefully that decreases, the goal is to decrease aspiration. But again, just making sure that they are intubated correctly. That's obviously not your job though. So atelectasis, this is most common postoperative pulmonary complication. So if you guys remember, atelectasis is basically just closure of the pockets of the lung in layman's term. That's usually what I tell my patients. There are areas of your lung that are not fully inflated. This usually happens within like the first 2 days. It's very common, especially in my world, in the cardiac surgery world, this is very common. Most of them are asymptomatic though. They might have, a little bit of hypoxia, so they're on oxygen, or there might be a little bit dyspneic. There are times that they can have fevers. They're not going to be your big fevers, though. It could be low grade, typically. And then almost always their exams are going to have decreased breath sounds on whichever side that they are on. From a chest x-ray side of things, you're going to see air bronchograms, elevation of the diaphragm. If you're post-op day 2, I'm not sure, unless you have a really high suspicion, I'm not sure you need to confirm if it's atelectasis with a CT scan. But because this is common, right? For these people, I always encourage their incentive spirometer and ambulation because it's going to help. And then if they need CPAP or BiPAP, it's probably because they needed it beforehand anyway, but that can be helpful as well. The biggest thing is if we leave atelectasis for 3 days or more, it's going to proceed, move forward, progress to pneumonia, right? Because we're just allowing these pockets of lung to collapse, and bacteria love those little pockets. So the goal is to make sure that we are doing everything we can during that time frame, getting them up, having them do their incentive spirometer so that they don't progress to pneumonia. Because the reason we don't want that is because pneumonia is the most common pulmonary complication when we are evaluating postoperative deaths. Mortality rates are high. That's probably an older statistic. I think it happens, but these are important things, right? Generally, the reason that the mortality rate is so high is because you're talking ventilator-associated or hospital-associated pneumonias, which, as you guys know, just carry higher risks than like your community-acquired pneumonias. These patients almost always get fevers. They have new radiographic infiltrates. They're hypoxic. They've got stuff, if you're post-op day 4 and they're like, man, you're still on oxygen, I usually say, are you coughing? Are you coughing stuff up? And they're like, oh yeah, I've got more gunk that I'm spitting out, right? So these are people that you need to follow closely. Again, like we talked about, it's often polymicrobial. They might have either had an aspiration or it's from the ventilator. So these are things that, you can get a bronch, you can isolate it, you can start them on empiric antibiotics. I don't have one here because, like a treatment regimen listed, because almost every hospital is different, right? Because they know what is most common in their hospital, and so they have a specific ID recommendation. So really you need to defer to your hospital hospital-acquired pneumonia recommendation. There we go. All right, so pleural effusions, as you guys know, is fluid around the lung. This is pretty common, especially in my cardiac world. Same thing with thoracic. These in general, you can get a chest x-ray. They've got the blunted costophrenic angles. Most of these are usually pretty small and they're going to resolve on their own. From a cardiac thoracic surgery side of things, you're probably going to diurese them because it could just be from volume overload. And then during surgery, you're already putting in chest tubes at that point to help with the drainage. So those are kind of specific just to that. If it is a large effusion, then you may need to do a thoracentesis if it's more than 25% of the lung space. So fat embolism, this is more of a boards question. Okay, you don't see this very often. It's usually pretty rare, and it is a clinical diagnosis. There's no one test to confirm it. This usually happens within 12 to 72 hours post-operatively. This is like classic. The question will be, there's petechiae over the axilla, chest, and proximal arms. They have neurologic dysfunction and respiratory insufficiency. It's going to be a fat embolism. Sometimes they can have a decreased crit and some thrombocytopenia, but these people generally just need supportive treatment. So I'm going to take a break and switch videos here because I am running out of time for recording here.